Hello, I'm Nandita Guha from MD Anderson Cancer Center in Houston, Texas. I'm co-moderating Session 13, which is a SAM session on post-treatment imaging, along with Dr. Ed Castle from University of Toronto. It is my pleasure to introduce the next three speakers in the second half of this session, starting with Dr. Julie Bukowski, who is a professor in radiology at UC San Diego Health in San Diego, California. She will be enlightening us today about post-immunotherapy changes and what to expect.
Thank you for joining this discussion on immunotherapy-related changes for the SAM session. I'm Julie Bukowski. I'm faculty at UC San Diego, and here's my disclosure, which doesn't have any relevance for the information being contained in this talk. So since the FDA approval of immunotherapy agents for solid tumors, more and more patients have had access to these treatments outside the scope of clinical trials. As neuroradiologists, we all need to be aware of the differences both in the response and the potential complications of these immunotherapy agents and how they differ from chemotherapy in order to help our referring providers understand both the surveillance imaging we see and their patients' symptoms. I'm going to focus on our case experiences and show you some images about patients who are undergoing immunotherapy for head and neck cancer, and also some examples of patients who are taking immunotherapy for other primary tumors who also had imaging of their head and neck. So we're going to start here. So together, modern immunotherapy agents are often referred to as checkpoint inhibitors, or you'll hear monoclonal antibodies. They target a single molecule. And I put the hello name there both as an introduction to the agents, but also to draw your attention to the SAM questions. So the two classes of FDA-approved agents are the CTLA-4 inhibitors, and they activate T cell production. And then there's the PD and PD-L1, the programmed death receptor and its ligand. Those inhibitors work on either the T cell or the tumor side, both sides of what they call like the lock and key relationship, to delay exhaustion of the T cells by the tumor antigen. There is also a combination therapy agent where IPI and NIVO are used together in treatment, and that combination was initially FDA approved for advanced melanoma treatment, and most recently it's become a first-line treatment for metastatic non-small cell lung cancer in combination with therapy. And I only put one slide in here because I wanted to not delve too deep into this, but just hit the importance that you need to distinguish that the mechanisms that activate or delay the death of T cells, particularly for those of you seeking SAM credit, but as immunotherapy benefits and the side effects are going to be different from that what we see from cytotoxic chemotherapy, which targets the rapidly dividing cells. And it's different from molecular target-specific agents like cetuximab for the EGFR or Avastin for BRAF or the CAR T therapy, where T cells are engineered to express cancer-specific antigens. So it's about this mechanism that's going to be explaining some of the changes that we're going to see. So let's get on to some cases. Here's an example of some of the node changes on immunotherapy you may see. There can be an increase in node size prior to the node responding, and this can be confusing because it may reflect tumor growth until there's a sufficient immune response, or it may represent a transient immune cell infiltration. These images are from an 86-year-old man who had squamous cell recurrence at his laryngectomy reconstruction margin, and he had pleural, pulmonary, and bone metastases. And I have his baseline images there on the top, and then 2 months later as a comparison that he had a very nice response at the recurrence at the laryngectomy margin. And you can see initially that low left neck lymph node was very, very small and had normal architecture. And at 2 months, it was a little larger, but it wasn't concerning. This patient was on a trial that had both pembrolizumab and cetuximab. And he had an infusion reaction to Cetux, so he was maintained on Pembro. And what you see on the lower images from 4 months to 6 months was this lower left node slightly increased. And then at 6 months, it developed cystic changes. And at this point, we were all very concerned, where he had had a good response initially, certainly at his primary site, but now we're seeing this node that's been increasing and now has frank cystic changes. So it was planned to take him to neck dissection, which took a few weeks to get to that point, and they re-imaged him right before there with ultrasound and said, hey, this node's decreased. So rather than pursuing excision, they continued him on surveillance, and he completed a total of 31 cycles of Pembro over 16 months. And this image at 14 months afterwards shows continued response in the node. And so we see some of these changes that happen, and the tincture of time is helpful, but sometimes it may be important to also go in and biopsy. And so I'm not demeaning the importance of that, but just being aware that we have infiltration and responses that can happen while these patients are on therapy. And here's another case highlighting the importance of doing short-term interval surveillance. So when we consider progression, we've been using the I-RESIST criteria for clinical trials, and that requires suspected progression of disease based on imaging to be reassessed at least 4 weeks and up to 8 weeks later to confirm that the changes are persistent or progressive. This patient here was a 53-year-old man who was already on his second clinical trial for recurrent metastatic mandibular squamous cell carcinoma. And he had lung and mediastinal node metastasis. So he was being treated with a Ipi-Nivo combination since he had already previously been on a trial with Pembro. And here's his lymph nodes that you can see 10 months after starting, his axillary lymph nodes look perfectly fine. And then 2 months later, he had bulky left axillary adenopathy. And then 4 months later, they're back to normal again. So this is an interesting pattern that we're seeing again. He was actually being considered for enrollment in another trial, but the nodes had returned to a normal appearance. And he had had a sustained response for his pulmonary disease for a year. There was another follow-up CT another 4 months after this last one that I show there that confirms no progression. And he's now 10 months out from that, that more recent scan that's there as well. I'm switching over here to PET because there's always got to be a case to remind us that not everything that is PET avid is malignancy. Although just as in this one, there's always going to be the need to prove that. We don't just rely on the images as well. This was a 62-year-old man who had P16 positive tonsil squamous cell carcinoma, and he was being treated on a clinical trial at our institution that was combining immunotherapy with a first-line cisplatin and radiation therapy for head and neck cancer. So here's his PET at baseline, where you can see his disease within the tonsil and within the lymph node at level 2, the upper edge of it. And I included his baseline chest imaging just to prove we didn't have any uptake there at baseline. And then in the middle images, we have after 4 months, we've had a response at the primary site. He also had a very nice response in his node, but obviously we had a great deal of concern seeing new areas of mediastinal lymph node uptake. He went to biopsy given the concern of this about whether or not to keep him on the trial or not. And the biopsy confirmed that this was granulomatous disease. There was no malignancy in the mediastinal lymph nodes. And here's his PET 1 year and 10 months out, which shows the response to therapy, which has been durable to this day. I put the citation at the bottom. This was just one of the patients from a multi-center study that we participated in, but there's the reference as well if you're interested in learning more about this cohort. It was very exciting for us for a preliminary standpoint about how immunotherapy may be considered with agents as part of frontline therapy for locally advanced and metastatic head and neck squamous cell carcinoma. I've included this one here for mixed response because there's a known dissociated or paradoxical response that can happen with immunotherapy across different organs. Particularly, this has been reported with adrenal lesions, but we also sometimes see a mixed response where some lymph nodes are decreasing while others are increasing. And again, this reinforces the need that sometimes you need to do short interval surveillance and sometimes you need to go sample. In this case, the initial scan, this is a 37-year-old man who had Crohn's disease and then developed neuroendocrine nasopharyngeal cancer. He had been originally treated with induction chemo, combined chemoradiation therapy, and had a very quick recurrence into his neck and to his lymph nodes after his initial standard of therapy. Here's his baseline exam, and you can see the bilateral level 2 lymph nodes, and also we can include the lower cystic one on the left. just as a representative, he had much more extensive adenopathy. But after 2 months on immunotherapy, and he was doing the combined Ipi-Nivo, you could see that your upper lymph nodes were increasing and becoming more frankly cystic, while the lower node was actually getting a little bit smaller. And so we sometimes see discrepancies on this. He did progress ultimately. And so it's again one of those things that you may see paradoxical reactions or some increasing or not. Unfortunately, he ended up with both adrenal, retroperitoneal, and brain metastases. So there's also a separate phenomenon called hyperprogression, where tumors have shown more than 50% growth after initiating immunotherapy. I'm very thankful that we've not had a case of that at our institution that I can share with you. But it is a known phenomenon that has been described, and the mechanism is not clear. It has been found more common in patients who are over 65 years and those who have recurrence in previously irradiated areas. But it's unknown if this hyperprogression is triggered by the immunotherapy itself or may just be a characteristic of very aggressive disease. But obviously, when you see that rapid doubling, that correlates with a poor survival rate. We do not know at this time what the underlying mechanism or all of the risk factors to be able to predict who shouldn't go on immunotherapy from that standpoint. I'm going to shift now to talking about adverse events that you may see on head and neck imaging for patients who may be on immunotherapy for a variety of other types of cancers. So this table lists the reported incidence of different adverse events that have been reported in clinical trials. And I would like to call your attention to the information in the green italics, as it may be useful for your SAM question. So thankfully, these complications can often be resolved with steroids and often do not require ending immunotherapy in all cases. And even if a patient needs to go off immunotherapy for a while, some can be re-challenged and continue their therapy. So we're learning about these as well as it comes. For our head and neck imaging, the ones we see are thankfully uncommon compared to the dermatologic or the GI-related adverse events. But it's important for us to recognize that when we will see these on head and neck imaging, the patients are not usually referred for that symptom specifically. Some of these endocrine abnormalities can present as very non-specific symptoms and may not already be identified clinically. And so you may be the person identifying it on someone's routine surveillance scan. And so you need to have a heightened awareness and a familiarity that the patient is being treated with immunotherapy, even if it's not a head and neck cancer that's primary. So endocrine, we have the thyroid, we have pituitary with hypophysitis, and then we have several that can happen with the eye itself, with uveitis, myasthenia, and others. I included the rare grade 3 and 4 neurologic down here, but I'm going to focus on ones that we're more likely to see on our neck CTs and MRIs. So here's hypophysitis. There's 3 images here that are sagittal T1 brain MRIs. This is an 88-year-old man imaged prior to and then 3 months after initiation of immunotherapy for his metastatic scalp melanoma. And I didn't show a SELA MRI on purpose because no one was suspecting immunotherapy-related adverse events. This is what you get. And so the middle image reveals enlargement to the pituitary gland corresponding to this hypophysitis. But unless you're looking for it, you're not going to find it. So it's important to remember this is a differential from metastatic disease to the pituitary gland. This patient was treated with steroids for his progressive hyponatremia, and then imaging 6 months later on the right shows resolution. And the timeline of this really varies. This can occur early on or may occur up to 4 months into therapy. And so while the reports vary, hypophysitis has an incidence of between 0.4 and up to 17% associated with IPI. It more commonly results in anterior pituitary dysfunction, but it's not exclusive to the anterior pituitary hormones. And I thought that the last bullet point here is important as well, is if you do have someone referred for possible hypophysitis in immunotherapy, a normal MRI of the SELA does not exclude the diagnosis. So again, our threshold is noticing that this middle image had an abnormal pituitary gland for an 88-year-old man, as well as a change from his baseline, and having the question to say, is he on immunotherapy or should I be looking for something else, and calling it to their attention. The thyroid example here is a 66-year-old man. He had had 2 different cutaneous melanomas, and he presented with lung and hilar nodal metastases 20 years later, so very delayed. 2 months after initiation of a combined Ipi-Nivo immunotherapy, he had hepatitis and thyroiditis, so 2 different adverse related events to his immunotherapy. He was treated with prednisone, he was tapered off, and then he was able to be restarted on immunotherapy. And I included his PET because you will see these. You may see it on ultrasound, you may see it on CT. And so at his baseline, he had a perfectly normal looking thyroid gland. At 2 months, we started having the PET avidity, which actually persisted during his steroid taper. But 1 year out, we can see that that's resolved. It's back to background levels. One of the things that's important to remember on this is that the test for primary thyroid dysfunction versus this being related to the pituitary axis can be inaccurate in the setting of acute illness. And so sometimes we can be very helpful about localizing for them about where area they need to be treating on this. Okay, let's go to the next one. And then following from thyroiditis, the impact can also be thyroid toxicosis, hypothyroidism, hyperthyroidism, and then thyroid eye disease. So this was an interesting patient. The coronal MRI shows enlargement of the inferior rectus muscle, right more than left, in this 60-year-old. He came in with new blurry vision, and he was being treated on Ipi for metastatic melanoma. And we thankfully had a prior MRI from 9 months earlier when he was asymptomatic, but they were scanning his brain as part of his melanoma workup. And that confirmed that he had a normal appearance of his extraocular muscles at that time. So after the MRI, we called the referring clinician, he had blood work, and they confirmed his elevated TSH. There can also be separate immunotherapy-related myositis. It can occur in the cardiac muscles and it can occur in other muscles. There's been case reports in the head and neck specifically that have contributed to swallowing dysfunction. So this was a case related to his thyroid eye disease, but you can have a separate immunotherapy-related myositis as well. And then I included pneumonitis because while it's technically not the domain of head and neck radiologists, we all need to be familiar with what can go on in the lung apices. And so this is a baseline CT on this patient. She was an 89-year-old who had metastatic salivary ductal carcinoma. She was started on Nivo as well as a targeted therapy PARP inhibitor for her disease. And her baseline CT confirmed she had a clear right upper lung. But 8 months later, she developed some new consolidation that was seen on her PET CT and some new ground glass opacities, and they had moderate SUV. So her subsequent chest CT showed a pattern of organizing pneumonia, which unfortunately we're all getting familiar with seeing now for other reasons. But her immunotherapy was stopped at that time, and then she was started on a steroid taper. Her chest CT 10 months afterwards confirmed her response, and since she had had systemic response to her disease on Nivo, she was able to be rechallenged, and she had no complications 3 months out from her therapy, which was the last time we had it recorded. So the important thing about pneumonitis related to immunotherapy is it can mimic lots of other things, and it can be very difficult at first presentation to figure out if this is what's going on, or is this a hypersensitive pneumonia, an organizing pneumonia, ARDS. And so the severity is graded by the patient's symptoms rather than what it looks like on imaging. But the important thing is to recognize that there is a new change in the lung apices, and if for any reason the patient has not had a dedicated chest CT at the time, to make sure that they do get comprehensive evaluation at that time as well. So I'm going to touch briefly on immunotherapy and CNS metastases. Even though this is not really our area for head and neck specifically, there is some overlap of areas that I want you to be aware of. One of them is that when many of these trials and drugs were going through initial approval, particularly for melanoma, Patients who had intracranial CNS metastases were historically either underrepresented or completely excluded from the immunotherapy trials. So there is a lack of knowledge about how these agents work in metastatic disease and what the natural history is, that we are still learning and still discovering, particularly now as more of these agents are becoming approved for first-line therapies in different solid organ tumors. There are some small cohorts with patients on IPI or combo IPI-NIVO or on Pembro for systemic disease who have shown response in their asymptomatic brain metastases. So these are small lesions or lesions that are not requiring steroid therapy, and they're not going to radiation therapy right away. There's also some retrospective review data about an association of symptomatic necrosis in the patients who have immunotherapy and radiation therapy. So this is another part of understanding the blood-brain barrier and what happens, as well as what happens when we're treating with immunotherapy and radiation therapy at the same time. That's a whole other area of investigation that's going on. So it's very important to participate in these clinical trials that are designed specifically to look at what happens with steroid therapy during immunotherapy, what we're doing with combinations of our agents and with targeted therapies and with radiation therapy to best think about how to treat these patients. This was an example that we had published a few years ago, who was a 43-year-old man who had nodal hepatic and bone metastatic recurrence of his lower extremity melanoma. He had no evidence of CNS disease when he was started on IPI-NIVO combination therapy, but within a week of starting, he came in with a new headache, and his brain MRI confirmed he had multiple enhancing and hemorrhagic metastases. Immunotherapy was continued in him, and rather than rushing to radiation therapy, they repeated his MRI 6 weeks later, and there was hemorrhage into the dominant left parietal lesion, but he had no new deficits. And so he was continued on immunotherapy, and after 6 months, he had no new residual or enhancing lesions. And now, since this was published, we've had other patients with melanoma, renal cell, and lung cancer who have had similar courses where we're seeing their intracranial metastatic disease respond without steroids, without radiation. Ultimately, this patient did progress with new brain metastases, but these original lesions never recurred. And so this is an interesting shifting discussion about when to radiate smaller asymptomatic metastases in patients who are responding to immunotherapy for their systemic disease and responding for their CNS disease. So as a neuroradiologist, it's imperative for us to understand how the treatments our patients are undergoing may impact the interpretations of their imaging. And while progression remains the most common reason for node enlargement during immunotherapy, short-term follow-up in 4 to 8 weeks or sampling may be needed to confirm progression. We also must be alert to the adverse events that can occur, as the scans are not often ordered for that clinical purpose. There are many endocrine-related adverse events that can resolve with steroids, and patients may be able to be rechallenged with immunotherapy. And we still have much to learn on this. There are exciting trials with new agents, with combinations and sequencing of agents. We're seeing more and more therapies emerge as part of first-line care for metastatic cancer, and there is promise for agents to be able to treat CNS metastases and delay or avoid radiation. So please do support your investigators with their clinical trials. I've included here some references which will obviously lead you to others. At the time we recorded this presentation in July, some reports were just coming out about oncology patients who became infected with COVID, that there was a higher hospitalization rate amongst those on checkpoint inhibitors, but the data was from the first wave of COVID in New York just through May, and there was a lot of heterogeneity across tumor types. So we expect this to continue to emerge as we are all learning to deal with this and exploring more. But I welcome any comments. My email address is here, and I look forward to seeing you all face to face when ASHNR is able to reconvene.
Our next speaker is Dr. Ashley Aiken, a professor in radiology from Emory University in Atlanta, Georgia. Her topic for today is going to be the importance of NI-RADS and tips on its implementation.
Good evening. Since it's officially cocktail hour for the East Coasters, maybe some of you are enjoying a cocktail now, which could really make NI-RADS even more interesting. I want to start by thanking Alona and the program committee for inviting me and all of their hard work on this virtual meeting. I look forward to seeing many of you tonight at the virtual reception. So in this session, you're already hearing from the experts, 5 outstanding speakers on all of the imaging tools that you need to be highly efficient and effective at reading post-treatment NECs. Understanding the normal post-operative appearance. I'm glad that Dr. Corey is again tackling flaps and reconstruction. Understanding how to differentiate post-surgical changes from recurrent tumor, post-radiation changes from recurrent tumor. What are the typical post-immunotherapy changes? And then finally, after this talk, you'll hear from Dr. Brandstetter on how to utilize PET in post-treatment imaging. And all of these tools are going to be critical in using NI-RADS. But today, I'm going to focus on its importance as a framework for reporting to improve communication, to give you confidence and add clarity to your reports. Recently, I gave a webinar on how to use NI-RADS in head and neck cancer surveillance imaging. And this talk gives a more comprehensive overview of what and when, why, and the how of NI-RADS and provides a lot of case examples. And you can find this, it's still up on the ASNR site, the mycrowdwisdom.com. But for today, I've been asked to focus on 2 things. Why is NI-RADS important, and how can I implement NI-RADS? The goal of ACR-RADS in general is to reduce variability of terminology in reports and to ease communication between radiologists and referring clinicians. And just as a reminder, NI-RADS is a risk stratification system and template for surveillance imaging after treatment for head and neck cancer, with 4 categories of suspicion and a category 0 for an inadequate evaluation. The major goal is to standardize the way we describe and report findings in order to add value and to guide management. So why is NI-RADS important? There are many reasons, and in fact, you may discover even more after you start using it. One of the biggest reasons is that it simplifies communication. By unifying the language between radiologists and referring clinicians, the clinicians often come and ask me, is the primary site a 1 and a 2? They will even sometimes use it in their own notes. These numerical levels of suspicion are an easy way to communicate. And I often give this example, but here's an impression from a report which does a great job describing the abnormality, but in the end the radiologist concludes that it could be neoplasm, post-radiation mucositis, or an infectious process without giving a level of suspicion. So this brings us to the second reason that it's so important to add value, in that there's clinical recommendations and guidance associated with the levels of suspicion. The framework also helps radiologists to confidently commit, understanding that it's okay to be unsure of the diagnosis, but you need to be sure of the next step. And because there's an I don't know category with a flowchart of findings and reasonable options for next step, it gives the radiologist, even with less head and neck experience, more confidence. NI-RADS is also important to help standardize care. When you actually start to use scores, you uncover different reading patterns with your partners, thresholds, etc., ones that you know exist, but are easier to start to examine when you have numerical levels of suspicion. So this, as we'll talk about later, facilitates the work to reduce inter-observer variability. It also helps to facilitate RAD path correlation. The webinar that I referenced earlier contains examples of why this is so important for the individual patient, but also for our growth as radiologists. For example, you may start to see that you're calling a NI-RADS 3 over and over again in a particular scenario, but finding out that it's always post-radiation, and then you may need to adjust your threshold. NI-RADS allows consistent data collection. There have been several studies looking at the prognostic value of NI-RADS, and this is one of them. This graphically shows that increase in NI-RADS score demonstrates higher probability of recurrence over time. NI-RADS provides an avenue to evaluate inter-observer variability. As we've already discussed, when you're using PROS, it's really hard to look at this. It's really hard to make a change. There's a recent publication in H&R looking at this, and there's a pending publication from our NI-RADS committee looking at inter-observer agreement across 8 different institutions at multiple levels of experience. NI-RADS also has revealed to us potential common pitfalls among radiologists. And one of the big examples at our institution was overcalling mucosal abnormalities after radiation. And again, an overcalling mucosal abnormalities also creates friction with our surgeons who think of the mucosa really as their purview. So that's been an important nuance and change that we've made. It is a great framework for patient discussion. Very powerful to know the probability of tumor based on a NI-RADS score in order to discuss the best next steps with a patient. As I started to prepare this talk and thought about how to implement NI-RADS, I realized that many of you have asked in the last couple years, and I, of course, could spend hours giving advice on how to implement NI-RADS, but we all have a different experience, different institutions, different practice. So I thought it would be most effective to reach out to some of those institutions that started using it and understand their experience. So thank you to those of you that I reached out to for responding. It really helped me to put this talk together and hopefully make it more practical for people that are thinking about using it. So I asked 5 questions. Are most of your radiologists now using it? If not, what are the major concerns and obstacles? Did you start with a meeting with the stakeholders? So the head and neck surgeons, medical and radiation oncologists. Did you start with a meeting with your head and neck specialist? Does your group have a general protocol already in place for surveillance? Overwhelmingly, the answer to this question, as we'll discuss, was no. Do you include the legend in your reports? And finally, have you gotten any feedback on how your referring clinicians and radiologists like NI-RADS? Using this information, I came up with 6 steps that we're going to review on how you can implement NI-RADS. The first step is to talk to your head and neck specialists, the stakeholders. The second is to introduce the categories of suspicion and the template. The third is to talk about all the possible natural next steps on how to manage patients in a post-treatment surveillance time period. There are limited steps, so that really helps the task feel less daunting in coming up with management guidelines. Then discuss your institutional approach to surveillance. Talk to your radiology colleagues, repeating the numbers above. But when you talk to the radiology colleagues, you're going to talk and focus on the benefits to them. A couple of institutions actually started first with their radiology colleagues before the head and neck specialists. And this really depends on a number of things, your individual practice, your relationships, etc. And finally, collaborate with other institutions that are already using NI-RADS to understand how they implement it, also to come up with projects moving forward using NI-RADS. So the first step is talking to your head and neck specialist. Most of you accomplished this with a brief presentation at Tumor Board focusing on the benefits to the referring clinicians. So it's trying to think of what they may find helpful, including less hedging, more clear communication of a suspicion level that more easily maps to them what the next appropriate step in management should be. Notice we're not telling them the next appropriate step, but we're helping to map that with our level of suspicion. You can show them the number of studies that have looked at the prognostic and predictive value and how you can use this as a framework for patient counseling. But what we shouldn't do, which often makes referring clinicians bristle is that we want to tell them what to do. Of course, that is not what we want to do. We don't want to tie anyone's hands. This is really about adding value for patients. The next step is just to introduce the levels of suspicion. This shouldn't be controversial. Should be a fairly easy sell. Many of you may already be reading based on sort of a 3 or 4 level schema. So either a normal scan, an abnormal scan, which maps to 3 or 4, or an indeterminate scan mapping to 2. When you kind of go through these levels, I think the referring clinicians appreciate having more commitment from radiologists rather than less. And then you can go into the nuances of whether it's mucosal or deep. You can share the data of recurrence rate by category and the increase from NI-RADS 1 at 3.8% to NI-RADS 2 at 17.2% to NI-RADS 3 at 59.4%, justifying a biopsy for those NI-RADS 3 patients, but not obviating a biopsy because the positive predictive value isn't high enough to justify moving straight to definitive treatment, salvage treatment, or palliative care like the NI-RADS 4 patients. Share the template. Focus for your referring clinicians on the appearance of the impression. The NI-RADS category will be assigned to the primary and to the next separately as they are managed separately. You should also include the numerical level of suspicion, but also the linked prose description for clarity. For example, NI-RADS category 2, low suspicion, and also the description of the finding that led to your decision to make these reports very easy to understand. The next step is to list all possible management options. There aren't that many, so listing these out makes your job seem less daunting. You can either do nothing. You can have a shorter follow-up, whether that's imaging or a mucosal exam. Different imaging modalities, so a PET for problem solving, tissue sampling if you're really worried about a lesion, image guidance or surgical, and then finally salvage treatment if a patient is a candidate for salvage treatment, or palliative treatment if they are not. You can easily group these management options based on suspicion level. So if it's an NED scan, of course you're going to stick with your routine surveillance. If you have an indeterminate scan, that means you need more data. And that more data may come in the form of a shorter imaging follow-up, or clinical or mucosal exam, or a different imaging modality like PET to help downgrade to a NI-RADS 1 or upgrade to a NI-RADS 3. If you're highly suspicious about an abnormality and it's discrete, then you're going to recommend tissue sampling. So these, again, become much more obvious and less controversial if you list the options, then you map them to suspicion with the surgeons. You can see you're not trying to tell them what to do. Most of these become self-evident. You're not going to go straight to salvage treatment or palliative treatment unless you're very sure. So those definitive recurrence cases based on clinical or imaging features. Another way to look at that, you're either going to have a negative scan or those scans that are definitely positive, the high suspicion, definitive recurrence. Those are usually not the controversial ones. The controversial ones are those in the middle, the indeterminate or low suspicion, and there are limited options. You can either bring them back earlier, recommend a mucosal exam if it's mucosal, or try a different imaging modality as a problem solver to help either move that category up to a high suspicion that needs tissue or downgrade it to a NI-RADS 1. You do not have to include the legend in your report when you implement NI-RADS. Some feedback is that a few surgeons or oncologists may feel that the legend ties their hands. While I don't agree with this sentiment as a radiologist, we already do and we should suggest next steps in many of our reports. However, NI-RADS can be effective to accomplish all of the goals that we've outlined, even without putting the legend in the report. You can share it with your referring clinician separately, and then you can use the PROS category description with each numerical score in your impression. And that's what many of you are doing if your stakeholders are worried about this. Institutional approach to surveillance. Most of you responded no, and this was one comment. It is very frustrating. We've proposed ACR surveillance algorithm, but our head and neck surgeons and radiation oncologists just do their own thing. The most frustrating part is that some switch between CT and MR and PET-CT, often without clear reason, which makes comparison difficult. This is something we've brought up. We'll have to regularly remind. Sometimes it's justified, i.e. a new cranial neuropathy, so they want an MRI, but most of the time it seems random. If you can identify with this comment, you're in good company. So it's an important conversation to begin as a long-term goal, but you do not need to standardize everyone's approach in order to use NI-RADS. In fact, there's a paucity of data, so we have an opportunity in using NI-RADS to generate more data to understand the best approach. And there's variability based on individual clinician preference, the stage, the subsite, the treatment, etc. NI-RADS is an interpretive framework that can be applied to any institutional surveillance algorithm. But it's an important conversation to have, and you may uncover reasons that they're doing things that you can explain and potentially change. So ask them, are they using a first baseline PET contrast-enhanced CT? For the most part, we always do use a PET at our baseline post-treatment. I would say the exceptions are the T1 oral cavities or the T1, T2 larynx, but for the most part, we are. Follow up beyond this time point. Do they generally order contrast-enhanced CT or MRI? It's not important to make drastic changes to individual preferences during this first discussion because there's no one right answer. It may also be a one-off conversation that you have with individual surgeons or oncologists so that you can start to understand this in the background. You may not even do step 4 in the larger tumor board group if you think it's going to stir the pot too much. But it is important to understand the rationale for their current behavior. Is it based on literature, personal experience? Do they shy away from PET because of false positives? Is it institutional preferences? That's the way I've always learned in training. Really, again, you're asking them questions. It's not meant to be a judgment. Here's an example on drilling down on the rationale for current behavior. Some of you gave feedback that your surgeons weren't ordering as many PET contrast-enhanced CT for the post-treatment baseline, but only contrast-enhanced CT, giving reasons, costs, and false positives. So you drill down and focus on the false positives. Yes, that is a problem, but maybe an opportunity that you can explain to your surgeon the difference between a non-contrast PET CT and a post-contrast PET CT. Many of them do not know the difference, that one is read by nuclear medicine, one by head and neck radiologist, the improved anatomic details that may mitigate against these false positives, that most of the literature is really based on the non-contrast PET CT, with the exception of the literature from UPMC, which has done a great job in looking at this fused contrast-enhanced CT, and then review some of the advantages of having the PET with the contrast-enhanced CT, and I've included a couple that I've found in our practice. But these sorts of conversations are very, very helpful part of this experience. You can share the ACR NI-RADS surveillance algorithm with them, but remember this is the beginning of the discussion and not meant to change practice with surveillance at the time of the initial implementation. The next step is to talk with your radiologist. Why is this important? Share with them the buy-in from your head and neck specialist. Will this make their lives easier? This is where you focus on decreased reporting time and adding confidence. Will this make them better? Share cases and lessons learned. Encourage radiologists, but make it optional. Paul Bunch from Wake Forest shared that when he first started using this, people were choosing to use the NI-RADS template only 50% of the time, but that increased to 60 and then 75% in the second and third months respectively. So this is a good trend demonstrating that those radiologists were finding it at least helpful and not adding time to their reports. Share the template and then share the data and the resources. On the ACR site, the category descriptors, the flowchart on the ACR site as well. I want to thank all of you for your attention. Thanks to those of you that shared your success stories. I've included an implementation story here. Thank you for all. I'm also including some references for those of you who may be interested in implementing NI-RADS.
Our final speaker in this section is Dr. Barton Brandstetter, the Chief of Neuroradiology at UPMC in Pittsburgh, Pennsylvania. He will be talking to us today about the limitations and pitfalls of FDG PET-CT in post-treatment imaging.
It's nice to give this talk right after Ashley's talk on NI-RADS, because now I can reference NI-RADS and you'll know what I'm talking about. I can say, you'd probably call this a NI-RADS 3, but if I gave you the full history, you'll see why it's really a 2, or something like that. Let's get right into it. PET-CT is a powerful tool to assess patients who've been treated for malignancies of the head and neck, but interpretation can be difficult, particularly in the post-treatment setting, where the effects of prior radiation, prior chemotherapy, or prior surgery may change the way that we interpret the images. Also, there are many artifacts on PET-CT that are present both on pre-treatment and post-treatment imaging. We'll start with a discussion of some basic artifacts that occur in PET-CT. Then we'll move on to talk about inflammatory causes of increased FDG avidity that might mimic tumor recurrence. We'll talk about the importance of image quality and doing good PET-CTs in order to avoid imaging pitfalls. We'll talk about the proper timing of PET-CT in the surveillance setting. And we'll talk about some unusual patterns of FDG uptake that might be confusing. And then we'll talk about other tumors that might come in to complicate the situation. Let's start with artifacts. There are some very familiar artifacts that you all know on PET-CT. For example, brown fat uptake. This is a stark example of how extensive brown fat uptake can be, and you wouldn't really make an error in this situation. But here's a situation where it might be a little more difficult. Yeah, there are some clues, some additional areas of fat uptake, but there is one particular area that is super bright, and you might be inclined to think that that is an area of recurrent tumor. The key, of course, is to look on the CT and find that there is no enhancing mass in that area, so you know that it's associated with the fat itself. How about muscles? Essentially any muscle in the head and neck can twitch during the uptake phase and cause increased FDG avidity above its counterpart on the other side or other muscles in the neck. But there are a few muscles that are particularly prone to doing this that should be very familiar to everybody. For example, the pterygoid muscles often have asymmetric uptake. Here's one of my favorites. This is the inferior capitis obliquus muscle. I don't know why this muscle, of all the muscles in the head and neck, so frequently has asymmetric uptake on PET, but it does. Here's a very familiar one. Everyone, I think, is used to seeing these two dots in the middle of the neck. That, of course, corresponds to the vocalis muscles, the true vocal cords. And they frequently have uptake because you can't ask a patient not to talk for an hour during the uptake phase. One of the most confusing areas of muscular uptake is the tongue. Whenever you operate on the tongue or whenever you treat a tongue that has been affected by tumor, invariably that tongue starts to fasciculate in the post-treatment setting. So you frequently get large areas or small areas of FDG avidity within the tongue itself. These can be very confusing. It's often right near where the tumor was initially. You've got to correlate with your CT images and make sure there's no enhancing mass in the tongue. You need to compare to previous examinations and make sure that the configuration of the soft tissue within the oral cavity has not changed to reassure yourself that you're dealing not with recurrent tumor, but just with muscular uptake in the tongue. It can be very asymmetric. It can look a lot like tumor on the PET alone. Here's another post-treatment scenario in which muscular uptake can be very confusing. If you just look at the PET images here, there is a rounded area of increased FDG avidity in the lateral neck after neck dissection, very concerning for recurrent disease. Maybe there's a clue here in the maximum intensity projection, very linear, longitudinal. That sounds a little more like a muscle. But look closely at the shape of the outer neck. See how there's a nice normal contour here on the left, but on the right, the neck is sunken in. We've lost muscle mass in the neck. That's the trapezius muscle that we've lost. And now you've got a clue about what's really going on. This is a situation where we sacrificed the spinal accessory nerve and the trapezius muscle has atrophied. Look at that asymmetry between these muscles. What takes over that role? The levator scapulae muscle. That's what hypertrophies to compensate for the loss of the trapezius muscle. The levator scapulae muscle can look just like a mass. You can imagine what the clinical contour of the neck here is. This can look just like a mass clinically and of course radiologically, and you saw how much FDG avidity was in that hyperfunctioning levator scapulae muscle. A confusing overall appearance. The association with the muscle fibers with the FDG uptake is your clue, and a solid knowledge of this physiology, what happens when you sacrifice the spinal accessory nerve. This is another familiar one, compensatory uptake, really, really bright uptake on one side of the larynx. This is what happens when you have vocal cord paralysis on one side, the other side takes over, and you get increased FDG avidity on the side that's still working. This is probably my favorite example of physiologic muscle uptake. This is a patient who had tardive dyskinesia from psychotropic medications, and all of the muscles of mastication show increased FDG avidity. We call this the Wolverine sign. One of the clues that you're dealing with artifactual muscular uptake is the longitudinal configuration of the FDG avidity. But it's not a perfect clue. Sometimes you get fooled. This patient, even though it looks like longitudinal uptake, is really just a string of recurrent lymph nodes in the lateral neck. Here's a patient where there's clear asymmetric uptake in the lateral neck. This could be very confusing, except it's on the wrong side. Has this patient developed new lymphatic spread, contralateral metastases? No, this patient has atrophy of the parotid gland, and that's a normal parotid gland on the other side. Right? Patients who have surgery, patients who have been irradiated will frequently have diminished uptake within the irradiated salivary glands, and that asymmetry might be confusing. So this is glandular uptake. Here's another type of glandular uptake. What do you do when the entire thyroid gland lights up? Well, if the entire gland is lighting up, usually that is a thyroiditis and not a neoplasm. This can occur in response to therapeutic radiation, or it can occur from a variety of other sources of, say, subacute thyroiditis. It's when you see a focal area of uptake within the thyroid gland that you should become concerned. Some 25% of lesions with focal FDG uptake in the thyroid gland end up being thyroid malignancies. So when we see focal uptake within the thyroid gland, that's when we suggest a biopsy. Obviously, lymphoid tissue has quite variable FDG avidity both before and after treatment. We've been talking so far about PET artifacts that might be confusing in the post-treatment setting. How about CT artifacts? Well, streak artifacts off of dental amalgam are a constant problem for us. That doesn't change when we move to PET CT. You really can't see what's going on here. Thankfully, PET to the rescue, showing us this recurrence deep in the tonsillar pillar. Fusion artifacts are a real problem. We really, at my institution, don't use the fusion images directly off of the scanner because you frequently just get overwhelming uptake like this. I will tell you there is no cancer depicted on this examination. This is just an error in the dynamic range of the PET. We use third-party software to avoid this problem. Okay, let's talk about inflammation. After tumor, it is the other major way that you get abnormal uptake in the post-treatment setting. Infection can be very confusing in a patient who has undergone surgery. You can see there's a large mass here deep to the patient's reconstruction flap, right around the surgical clip, a perfect location for recurrent tumor, and this bulky mass, I called it tumor. Here is the CT after a couple of weeks. I thought maybe this is a response to therapy with a fistula formation. Here is the PET, and there's extensive FDG uptake. I felt like that really confirmed that this was all tumor. But they asked us to put a needle in it. We aspirated this, and pus came out. This is all a post-operative abscess. This is a familiar infection to people who read PET CT in head and neck cancer patients. Patients who have been treated for head and neck cancer often aspirate after their therapy, and so seeing aspiration pneumonia at the lung bases is a frequent potential artifact. Okay, this is an important point. Radiation causes inflammation in lymph nodes. I'm going to say that twice. Radiation causes inflammation in lymph nodes. At first glance, you might look at this PET CT and say, oh, there's some uptake in this left 1B node. That's pretty worrisome. I'm going to call that a NI-RADS 3. We're 2 months out from the conclusion of the radiation. But when you go back to the pre-treatment scan, the staging scan in this patient, there's plenty of lymph nodes, and 1B isn't one of them. This is just inflammation induced in an uninvolved lymph node from the radiation itself. That's a benign node. That should be NI-RADS 2 at worst. Another example, exact same concept. This is a rounded node. It's got a little bit of FDG avidity. You're going to be worried about that, but if this was an uninvolved node pre-treatment, then it probably does not harbor cancer. It is probably just a response to radiation, NI-RADS 2. Teflon injections. This slide has almost become anachronistic. We no longer use Teflon to augment the vocal cords because we realized it is not bioinert. It does cause an inflammatory reaction. So when you see uptake in a single vocal cord, and that corresponds to a well-defined hyperdense area within the cord itself, that is likely to be a Teflon injection to correct for vocal cord paralysis. If you think that this is enhancement and you see the FDG avidity, you can definitely see how this might be confused for uptake within a second primary or recurrent tumor. Healing bone has increased FDG avidity. Any healing tissue really has increased FDG avidity, but it's particularly confusing in healing bone in patients who have had reconstruction of their mandible and resection of an oral cavity tumor. Here's a patient who has extensive FDG avidity surrounding the reconstruction right where the native bone is meeting the bone graft. This is normal. This is expected. As this bone heals, eventually it will completely heal and there will no longer be abnormal uptake in that location. At first glance, this maximum intensity projection looks like there's 2 lung masses, looks like metastatic disease out there, very concerning. Here's the CT correlate. These are rib fractures, and you can see that there's extensive bridging callus around these healing fractures. I think the clue here is that the 2 are right on top of each other, oriented like rib fractures often are. We often see uptake along the course of the thoracic esophagus. This is esophagitis, and it is almost always the result of gastroesophageal reflux. In this case, the inflammation goes all the way up to the piriform sinuses. This is a really worrisome appearance on a maximum intensity projection. You can see lymph nodes all up and down through the neck and out into the axilla, maybe just some reactive nodes in the mediastinum, but a very concerning appearance overall. This is actually a patient with sarcoid, autoimmune disease mimicking metastatic disease. How about foreign body reactions? When a patient undergoes surgery for head and neck cancer, we do all sorts of manipulations. One of them might be insertion of a foreign body. For example, this is a patient who had maxilectomy for squamous cell carcinoma, and you can see right in the face here, right where we'd be worried about a recurrence, there's a bright lesion on the CT with extensive FDG avidity. That's pretty concerning. But if you look more carefully at the CT itself, that isn't enhancement, that's calcium. This is micronized hydroxyapatite. It is an injected material that was meant to add volume to the face as a cosmetic repair after this surgery, and it's inducing a foreign body reaction. Okay, let's turn our attention now to image quality. If you don't have good pictures, you can't make good diagnoses. And the theme here for this entire section is going to be using intravenous contrast. There are a lot of political reasons in the United States why we don't like to do contrast-enhanced PET-CT. I frequently see situations where a patient will get an attenuation-only PET-CT and then on the same day will get a contrast-enhanced CT of the neck and chest. That is absolutely a waste, and you're doing the patients a disservice in those circumstances. Find a way to cut through the politics and do what's right for the patients. Here's a post-treatment patient. There's a little bit of uptake left in one of the salivary glands. The other one's been suppressed by radiation, so yeah, no big deal. No real concerns here, right? Well, wait a second. What's that? There's no FDG avidity there. That's got to be okay, right? Let me just blow that up and we can get a better look at it. When you look at it on the CT, there's clear mural nodularity and enhancement in this. There's a necrotic center. This is a necrotic metastasis. It's got no increased FDG avidity, but it is still abnormal. This is a situation where iodinated contrast saves us. If we just had an attenuation-only PET-CT here, and this had no uptake, we'd blow right by it or think that it was a successfully treated node. It's only once you see the necrosis and see the mural nodularity that you can make the correct diagnosis of recurrence. Here's a patient with a lot of FDG avidity out laterally. Turns out that's all muscular. Symmetric uptake in the tonsils. No big deal. But once we have iodinated contrast on board, you can actually make out the discrete mass in the tonsil, despite all the streak artifact. Discrete mass there that is the tumor. This is a patient who had an attenuation-only PET-CT for surveillance, and there's an area of FDG avidity there, but really nothing seen on the unenhanced CT component. Probably just a little bit of granulation tissue in there. No big deal. Unfortunately, this is that same patient 3 months later. You can see that that actually was recurrent disease there, and it has exploded. Unfortunately, we blew it off because we didn't have the intravenous contrast there to inform us of that diagnosis. I know I'm hammering this home a little hard, but I really believe in this. Here's another example where we had a little bit of FDG avidity underneath this flap, but wasn't overly concerning until we had a really close look at the contrast-enhanced examination, and you can see that's actually a retropharyngeal lymph node with some central necrosis to it. No way you'd be able to pick that out without the use of intravenous contrast. Another way to get bad images is to ignore blood glucose level. I know we all do this routinely, ensure that patients don't have a high blood glucose level, but if they get through, this is what happens. All of their soft tissues take up the fluorodeoxyglucose, and you can't make out individual lesions. Let's talk about timing. When should we be doing PET CTs? When should we perform the first PET CT after the conclusion of therapy? Most people shoot for about 3 months. The literature says that there's really no difference between 2 months after therapy or 3 months after therapy, so you can get a little bit of a jump on that and do it at 2 months if you like. If you go earlier than 2 months, you start to get into a range where you get a lot of false positives and a lot of false negatives. You get false positives because there's still surgical healing, and just like those examples of bone healing, the soft tissue healing after surgery will have physiologic FDG uptake that can look like tumor recurrence. Radiation effects work the same way. For several months after therapeutic radiation, there's still healing tissue there that can mimic recurrent disease. There are also false negatives that occur in this time frame. The tumor has not had a chance to start regrowing yet, so it may be too small to appreciate on PET. If we start going out to 4 months, 6 months, waiting too long, we may have lost an opportunity to cure the patient's recurrence that we would have picked up at 2 or 3 months. Even too soon after chemotherapy, we can see rebound of the bone marrow that may look like bone metastases. This is actually a PET CT. It looks more like a bone scan. But there are no mets here. This is just rebound after chemotherapy. We all base our interpretation on expected patterns of uptake. There are expected areas where we know tumor is likely to recur, but are there situations where unexpected patterns arise and might confuse us? Squamous cell carcinoma of the head and neck associated with HPV can sometimes result in bizarre metastatic patterns. We don't think about squamous cell carcinoma of the head and neck going down to the pelvis. In fact, it occurs almost never unless there are intervening thoracic metastases, but HPV is an exception, and you can get bizarre distant metastases with HPV-associated squamous cell carcinoma, like this isolated metastasis to pelvic lymph nodes. Be careful in the setting of bulky disease with a near complete response. We are so used to seeing head and neck cancer completely disappear when it has been successfully treated. But if you start with bulky lymphadenopathy, you may get an excellent response with just a little bit of CT and PET abnormality where a large node used to be. That's actually a good sign, and the literature suggests that these patients have a very high likelihood of being completely cured to the point where these should be called NI-RADS 2 lesions when you have bulky disease that has a near complete response. A complete response would get you to NI-RAD 1, but a near complete response should be a NI-RADS 2. It's not that suspicious. Do be careful though, because mucosal disease, while it may not go entirely back to normal on PET, should become just a thin residual rhythm of enhancement on CT. If you can still see bulky enhancing tissue at the site of a large lesion, that's still worrisome, and this should be in your NI-RADS 3 classification, or 2A if you want to get them just to look at it, 3 if you want to ensure that they biopsy it when they look at the mucosal surface. bone metastases can be very difficult to find on CT. Thankfully, it's PET to the rescue. I suppose there's a little bit of sclerosis there in retrospect, but I was going to absolutely overlook that sternal metastasis. Another example of hidden bone mets that there's no way I'm ever going to pick up on this CT. There they are. Even in retrospect, I had no hope here. PET to the rescue for hidden bone mets. Are there some pitfalls that occur just because PET-CT is not the right exam? Yeah, perineural spread is a great example of that. Every once in a while, you'll be able to pick up perineural spread on PET, but it's certainly not reliable for this diagnosis the way that MRI is. And in tumors that are likely to have perineural spread, or patients that have already documented that propensity in their tumor, you really got to be using MRI. Now, you could be really fancy about it and use PET MRI and kill two birds with one stone, but don't rely on PET alone to find that perineural spread. Tiny little metastases, obviously the most difficult thing that we encounter in imaging. You know, these mets have to start somewhere. They're going to be small before they're detectable, and PET can sometimes be helpful. Sometimes if they're necrotic, you need the CT. This is a great example where the fused PET-CT is far more powerful than either of the two component modalities alone. Small metastases. Another pattern that can be confusing is a delayed recurrence. We know that in the age of PET, 75% of recurrences can be detected within the first year after the conclusion of therapy, 95% within 2 years. So once a patient gets out beyond 2 years, we start getting a little cocky, we start getting overconfident. The likelihood that there's actually going to be disease is extremely low. I'm showing you the CT component of a PET-CT from a patient who's 38 months out, over 3 years out from the conclusion of her therapy. And sure enough, there's the recurrence. It's not that guy back there. There's the recurrence. Very difficult to pick up. Another weird or unusual pattern that we need to be aware of is the complete physiologic response. Sometimes you have a bulky lymph node that would have, before the age of PET, forced a patient to undergo a planned neck dissection. If we can document a complete physiologic response, that patient doesn't need surgery anymore. But it has to be a complete resolution of the FDG avidity within the lymph node. Even if it's still pretty big, if there is no more FDG, that patient can be watched as a NI-RADS 2 instead of undergoing a planned neck dissection. There are other tumors that we might encounter besides the one that we are looking for as we search for recurrences. Benign glandular neoplasms are famous for having abnormal FDG avidity. Warthin's tumor in particular, oncocytomas as well. These can be very confusing in a head and neck cancer patient where this might be a reasonable spread of lymphatic disease. But this is just a Warthin's tumor, benign. Glandular malignancies are just as dangerous in the opposite direction because glandular malignancies may not be PET avid. Now you can look at this axial image all you like. I don't think you're ever going to pick up this metastatic disease from medullary thyroid carcinoma. It's just not FDG avid. There's another example where IV contrast really helps us out because these glandular malignancies tend to be very vascular. Another example, same basic idea. This is a patient with extensive metastatic disease, and this maximum intensity projection really misleading. Numerous lung metastases from adenoid cystic carcinoma. This is an example to sort of emphasize how confusing it can be to distinguish glandular malignancies from benign lesions. There are bilateral masses in the thyroid gland here, and your job is to figure out which one of these is the malignancy and which one of these is benign. Good luck. That's a colloid cyst. That's follicular thyroid carcinoma. I've got no hints or clues. Second primaries are so common in patients with head and neck and lung cancers. We've always got to be on the lookout for a metachronous primary tumor when we're looking at surveillance scans. For example, this is a patient who had a squamous cell carcinoma of the oropharynx and on post-treatment scanning presented with this adenocarcinoma of the thoracic esophagus. And that concludes our whirlwind review of some potential post-treatment pitfalls of PET-CT.